Hello, everybody, and thank you very much for joining us for this session. It is brought to you by the Goen Institute via a group of us who came together and thought of ways of helping our members of the senior community. Today, we are privileged to have with us Dr. Helen Musau, who I have known for the last 25 years. Dr. Musau is a consultant clinical oncologist, now working at Kenyatta University, teaching research and referral hospital. She recently moved from Meru, where she was the head of department of the Meru Teaching and Referral Hospital. She is a member of various oncology technical working groups and has vast experience in palliative care. She's a charter member of the Rotary Club of Nairobi Ridgeways. Thank you so much, Dr. Musau, for giving us your time, and we look forward to learning as much as possible from you about cancer, which is a silent killer and has affected a lot of people, not just the patients, but family and friends. Thank you, Dr. Musau. Over to you.
Thank you very much, Lynette. When you say we've known each other for 20 years, makes me wonder if I'm just becoming a senior as well. And this week I've actually been referred to by my, some younger doctors as a senior colleague. So yeah, I think the talk is not just for seniors, it's for everybody. I will focus on just cancer awareness. I will not go much into detail about different types of cancer. I will not go into detail about treatment options and treatment of cancer, because it's not a one, size fits all or a blanket sort of treatment. I think different cancers have different treatments. So I wouldn't want to forget that this is a treatment for this particular cancer, because everyone is different. So I will focus on just awareness, risk factors, and looking to answer many of your questions that we have. So I'll just share my screen. Thank you. Okay. All right. So we'll discuss this afternoon what is cancer, what are the risk factors of cancers, the common types of cancer, focusing probably on Kenya, the signs and symptoms and the common signs and symptoms that we see for cancer, and the importance of early diagnosis when we're looking at cancer. Prevention, what can you do to ensure that you don't get cancer or that you catch it early? So cancer begins when cells in the body start to grow out of control. So we have billions and billions of cells in our bodies, and these cells grow, have a life cycle, a cell cycle, and they grow and die, and there's renewal every so often, or every so often, every number of days. But that's a normal mechanism in the body, and there's a good equilibrium of cells growing and dying such that the body continues to function as it does. But sometimes something happens in the body and you find that a cell gets a problem, gets a mutation many of the times, and it starts to grow out of control. And it grows causing problems where it is, in the particular part of the body that it is. But with time, it has the ability to spread to different parts of the body. And that is what we call cancer. So the progression of cancer moves in different stages. So it's not that you one day wake up and you just have cancer. You usually have to have undergone different phases. So there's a precancerous phase. And in the precancerous phase, we have different types of cells. So we have cells that look almost like the normal cells or a little bit bigger, and but are essentially normal. And that is called hyperplasia. I'm going to put it here. And then you have cells that look abnormal to the normal types of cells, but have not gone to become cancer. They have different grades and stages, and that is usually called dysplasia. And a lot of the time they can resemble cancerous cells, but they have some characteristics within them that are still normal. And then we have cancer that is starting out, which is carcinoma in situ, where you find that this cell definitely looks like a cancer, but it has not progressed to the point where we can say it's cancer. It has not crossed certain boundaries within the cell or within the tissues for it to become a cancer. So the progression from the precancerous stage to the stage where we actually now have overt cancer could take years. And in normal individuals or in normal situation, what happens is that the body has a mechanism in where it identifies these abnormal cells and is able to fight them and destroy them such that they don't develop into full-grown cancer. But sometimes we're not able to have those check mechanisms in place, and we find that a disease can progress from the precancerous stage to a cancerous stage. It may take a while. It doesn't happen in a day or two or weeks, but it takes a while, sometimes even years, for it to develop from pre-cancer into invasive cancer. Now we have things that we call stages that people talk about a lot of the time, like, somebody has been diagnosed with a cancer, what stage are they? And after the precancerous stage, we have now what we call localized, early locally advanced, late locally advanced, and metastatic disease. And in a nutshell, that's almost what we would term stage 1, 2, 3, and 4, such that in early stage disease, which is stage 1 and 2, you have it localized to a particular area where you find that it is in one area, not moved beyond there, but the rest of the organ or tissues are normal. In early locally advanced, you still have some normal tissues around there. It has not spread too much. It's still within the organ. Late locally advanced, it has started to spread outside of the organ, and it can do this by either breaching the boundary of that organ or the capsule of that organ, or spreading to the nearby cells or lymph nodes around there. And then when it's metastasized, it essentially means that it has moved outside its primary area and has gone to different parts of the body. That progression also can vary in terms of the time scale. Could take anywhere from years to months, where you get a disease being localized in one area to it being metastatic, having gone to different parts of the body. Now, what we're talking about is just cancer. So we're talking about invasive cancer or malignant cancer. There's a different type of growths in the body where you find that there's an uncontrolled growth of cells, but those cells do not spread to other parts of the body, and those would not be malignant, but would be termed as benign growths, meaning they don't ever move from the stage of localized. They just stay in the area where they started growing and cause problems there, but never really advance out of that area. So when we're looking at cancer today, our talk is basically focused on the malignant type of cancer, not the benign types of cancer. So what causes cancer? What are the risk factors? And the truth is, we do not know what causes cancer. At the end of the day, we have not been able to identify one sole thing that is, and say that this is what causes cancer. And it causes cancer for everybody. And that's why we say that we have only identified risk factors, things that have been shown time and time again to cause cancer in a population. And again, it would vary. It wouldn't be the entire population. So we have two types of risk factors, or we classify them into two. We have modifiable and non-modifiable risk factors. Now, the things we cannot be able to change are our age, sex, race, and family history. And you find that these can contribute to getting different types of cancer. So unfortunately, the older you grow, the higher your risk of developing cancer. And they usually say above the age of about 62 to 65, you're at a higher risk of developing cancer. If you're younger, your risk for developing cancer is always lessened by a great degree. That said, we do find cancers in younger people, including children. There are some cancers that are known to happen or to occur in only the pediatric population. So it's not that young people do not get cancer. We know that the risk is higher with older people, but we are slowly starting to see an emergence of cancer or an increase in the number of cancer cases in young people, and which is alarming for us. In terms of our gender, or our sex, our genetic makeup, sex, we find that cancers, there are some cancers that we will find in different genders, such that men are the only ones who can get prostate cancer, and women would be the ones that get ovarian and cervical cancer. We find that breast cancer is more common in women. Only about 4 to 5% occur in men. The vast majority still occurs in women. And there are other cancers that would occur more commonly in men. And for example, colon cancer, stomach cancer, and lung cancer would occur more in men than in women. Again, our race predisposes us to getting particular types of cancers. We find that also the cancers may be aggressive in different types of races. And those that are a little bit more common in Blacks or more aggressive in Blacks would be prostate, breast, lung, colon, and rectum cancer. We find the literature has shown that in the Black population that these cancers are a little bit more aggressive. Now, there's the question always of family history. Is this cancer genetic? Is this cancer genetic? Is it running in the family? Some cancers do run in the family. They have been seen to run in families, and most commonly will be breast, ovarian, colon, and prostate. But it doesn't mean that everybody who gets these cancers, that it is now a genetic condition. It just means that if there are many people in the family with a certain group of cancers, and those people were diagnosed at an earlier age in life, usually less than 50 years of age, then there needs to be more information, or they need to go for genetic counseling to be able to determine whether there is a risk of that cancer being genetic, whether it's a germline mutation that is passed from one generation to another. Now, the truth of the matter is less than about 5% or less of cancers are actually genetic. The vast majority of cancers that we do see do not run in families, do not have a genetic predisposition. And it is actually just a spontaneous mutation at the end of the day. So we find that, yes, you may have a history of cancer in your family, or 1 or 2 people may have cancer, but it's not a genetic link. So most of the mutations that we see would just be spontaneous mutations that happen and not genetic predisposition. Now, the things that you can change to prevent you from getting cancer, these are what we call the modifiable risk factors. So that's tobacco use, infectious agents, alcohol intake, dietary, and a sedentary lifestyle, and we'll just go through them one by one. And we say tobacco use, not smoking, because there are different ways in which people ingest tobacco. So there's chewing, there's sniffing, and there's smoking. And when we look at smoking, we're not just talking about the person smoking, we're also talking about those that are inhaling, maybe secondary. So secondhand smokers are also at risk of developing cancer as well. And it is one of the biggest preventable risk factors. Cigarette smoking has actually, or nicotine has actually been shown to be the biggest causative agent of nearly all cancers. It will run from head to toe. They will always be, when you look at the risk factors, tobacco use will always be one of them. And we also see it in a variety of other non-communicable diseases like cardiovascular diseases. It has been shown to contribute to the increased risk of strokes, hypertension, and even heart attacks. So if there's any take-home message today, it's stop tobacco use. And then we have various infectious agents that cause cancer. Some of them are bacteria, some of them are viruses, and some of them are parasites. When we're looking at viruses, which have been studied quite a lot, we have different types of viruses that are linked to different types of cancers. We're talking about cervical cancer, which is caused primarily by the human papilloma virus. This is a sexually transmitted virus, and we're looking to eradicate cervical cancer in the world one of these days. We've started vaccinations against HPV, which is the human papilloma virus, and we hope that in years to come, maybe our children will be able to experience a cervical cancer-free world. We have hepatitis B and C that are linked to the formation of liver cancer, and we have HIV that is linked to different types of cancers, including cervical, a specific type of brain cancer, blood cancer, and even specific types of skin cancers like Kaposi sarcoma. Then we have different, this bacterial agent that nowadays seems to crop up a lot, Helicobacter pylori. It's a bacteria that lives in the stomach and can contribute to stomach ulcers. which in time, if not treated well, will cause a lot of inflammation in the tummy that can develop to the formation of stomach cancer. So that has been shown to be a causative factor for the development of stomach cancer. Different parasites found in water many times, like schistosoma hematobium, can contribute to the formation of bladder cancer. It's seen in the rice paddies in Kenya most of the times. You will find a higher percentage of people presenting with bladder cancers. And then things like the liver fluke contribute to bladder cancer. So it's not just the alcohol, the drinking, the smoking. We have different infectious agents that can cause cancer. Then alcohol can also increase your risk of developing cancers, particularly in the mouth, the throat, the food pipe, which is the esophagus, the stomach, and the liver. The combination of alcohol and tobacco use increases that risk a lot more. Now, something that we always want to emphasize on is diet, nutrition. A diet lacking fruits and vegetables is not good. One that is rich in processed foods, meat, high sugars is not good. And they have been labeled to have causative factors, especially processed foods, that do lead to the formation of cancers. And the diet goes together with exercise or the lack thereof. So we always increased activity is good for the prevention of cancer. So a sedentary lifestyle is shunned upon. And then other things that we can modify would be ultraviolet radiation from the sun, which has been shown to be linked to skin cancers. It's worse in albinos, in fair people, in the Caucasian population, and people born with certain skin defects. We usually say that you should use a sunscreen on a daily basis. Avoid the midday sun. The sun between 12 or noon to about 2 p.m. should be avoided. You should not be in direct sunlight if you can help it. And use sunscreen or sun protective gear if you can. And then hormones. The estrogen increases has been shown to have an increase in the risk of breast cancer formation. Now, these are the common cancers that we find in both men and women across the world. In women, the top cancer is breast, and then lung, stomach, cervical cancer, and colorectal cancer. In men, the top cancer is lung, and then prostate, and then we have others like esophagus, stomach, liver, and colorectal cancer. You find that some of them are shared across both genders, like the lung, stomach, liver, colorectal cancers are common to both. Now, in Kenya, we don't have very good statistics, and the truth of the matter is we don't collect data from the entire country. So the data that we collect is just from select places that have either one, good data, meaning they have cancer registries, or they have confirmed diagnosis and keep those records well, so we can be able to go in. So there's an association that looks at cancer research across the world, and they issue out a report every year or every 2 years. So the latest one we have is from 2020 and shows that the number of new cases in Kenya is 42,116 cases, which is actually just shy of the truth. We know that there's a lot more cancer cases reported, recorded, but probably not, reported, but probably not recorded at the end of the day. Our top cancer in this country still remains breast cancer and cervical cancer, followed closely now by prostate and esophageal and colorectal cancers. Then the other cancers account for the rest of the 50%. These are our top 10 cancers. And you can see the first two, which is breast and cervix, are women-based cancers. And it's not that it's only women who get cancers. Men do get cancer, but I think women have a better health-seeking behavior sometimes. And also they're able to present earlier because these symptoms are quite distressing for them, particularly say like cervical cancer. They can't actually hide and say they don't have anything going on with them. So there's a different, categorization for children as well, where we look at the common cancers available for children. And then we also look at the rates in which or how well they do. And the truth of the matter is, most of the people diagnosed in Kenya with cancer are diagnosed in a late stage, meaning they're diagnosed in either advanced stages like stage 3 and stage 4. We are working hard to get people being diagnosed earlier. There are different efforts being done by the government, but we'll talk about that. Now, the case stands true for most countries in sub-Saharan Africa. They will have a similar pattern of cancers such as Kenya's. And again, they will also have a similar pattern in terms of when and how late the cancers are diagnosed. We just want to talk about some of the early symptoms of common cancers in Kenya, looking at prostate cancer for men and esophageal cancer, and then for women, looking at breast cancer and cervical cancer. So for prostate cancer, the prostate gland is very closely related to the urinary tract, meaning they will tend to have symptoms with urination. And this could vary from, a poor stream to difficulty urinating, to not urinating at all, to having sometimes even blood in stool, in urine. And when men get problems with their urine flow, they should be advised to seek the services of their general practitioner so that they can be screened to see if prostate cancer could be occurring. Cancer, which is cancer of the food pipe, your problem will start with feeding, and you find that patient will complain of a history, will say that maybe they were able to eat some meat, but suddenly they can't eat the meat. It's they feel like they're getting a choking sensation, or they find that they can be able to eat it, but they have to swallow something after they've eaten maybe some solid foods, or they can't eat solid foods at all and are now only able to take semi-solids. And those are symptoms that show that there's a problem with the food pipe at the end of the day. Now, for breast cancer, it's usually a lump or a swelling in the breast, and sometimes we also find it under the arm, which is an area we call the axilla. Others would present with just changes in the breast, meaning the skin would appear different, or they could have a discharge from the nipple that would herald that something else could be going on. And then for cervical cancer, most of the patients will present either a discharge that is not responding to treatment, or bleeding from the vagina, and when not on their menses, or even after their menses, when the patient is postmenopausal. These are other common signs of different cancers and signals for cancer. Doesn't mean that if you have them, you have cancer, but it would be good to seek the services of your general practitioner or your specialist. So a change in bowel or bladder habits. And this could be anything from either you used to be very regular and now you're having constipation, or you're having diarrhea, or you're feeling like you're straining when you're going to the toilet, or you're seeing blood when you're going to the toilet, or you're not urinating at all, and which is not normal for you. Another one would be a sore that doesn't heal, meaning you get an ulceration on any part of your body, and despite different treatments, it's just not getting better, or it disappears and keeps coming back, keeps coming back with different treatments. Then that should signify that that is not normal, and you need to have extra attention given to that sore. Any unusual bleeding or discharge from anywhere in the body, something that, we don't bleed on a daily basis, or we don't have discharges from any of our orifices on a daily basis. So if you have any of that, you should have that looked at and checked out. Thickening or a lump in the breast or elsewhere in the body. Any swelling that is not normal or seems to grow at a fast or even a slow rate should just be looked at for extra attention or a second opinion. Indigestion or difficulty in swallowing. And indigestion means that you should not be saying that you're having acidity or hyperacidity more than 2 or 3 times after treatment. If that is the case, you need to have somebody look into the tummy, maybe with a scope, to make sure that everything is fine. Same thing if you're having, change in bowel and bladder habits, or blood in stool or urine, then you should have that looked at if it persists. Any obvious change in a wart or a mole anywhere on the body. For those who are fair skinned, should have something called mole mapping, where a dermatologist is able to look at those moles and take the measurements, and over time keep looking at them and taking the measurements, such that if they do start to change, then we're able to notice those changes. But more often than not, we tend to just have them and think they're called beauty spots, but we should note that if they change in color, if they change in size, if they become ulcerated, or if they just start increasing at a fast rate, then we should have them looked at. And then any nagging cough or hoarseness of voice should not be ignored and should not be dismissed. Should always go in and have an opinion. At the end of the day, you know your body best. You know what is normal for you. You know what works for you. And if you go in and you keep insisting that this is not normal for me, even if you see one clinician, always seek a second opinion if you're not satisfied, because we as doctors listen to what you tell us. We say that common things occur more commonly, so we tend to treat what is more common. But if it is not responding to treatment, then we need to take steps to make sure that we're not missing something that could be worse. Now, what can you do for yourselves to be able to prevent some of these things that we've talked about? So it's basically the risk factors, trying to get rid of them. So avoid tobacco and tobacco smoke, if possible. Like we said, secondary smoking also causes a risk factor for the formation of cancer. Limit alcohol consumption. I know many people will ask me, what about red wine? They say that it's good, it protects the heart. But you can have some alcohol, but you have to limit your consumption based on your weight and also based on your gender. There are different units of alcohol that you can be allowed to consume safely. Then you can protect your skin from the sun by using protective gear or using sunscreen. Eat a healthy and balanced diet, and this cannot be overemphasized. A diet rich in vegetables, rich in fruits, lots of water, a diet free from processed foods, chemicals, and what are they called? All these chemicals that we see with names that we can't even pronounce. That's not natural. So try and avoid those things. And try and go organic. It came on as a fad, but it's actually good to eat a more organic diet at the end of the day. Then we need to control our weight, and we can do this by exercising daily, getting fit, getting active, moving. And even in these times of Corona, when we're not all able to go outside, we can still do exercises within the confines of our spaces in the house. So we should be able to exercise daily. And then get immunized if you are at the age where you could benefit from the immunization, such as hepatitis B or HPV, the human papilloma virus. You're encouraged to get immunized. And screening. This cannot be overemphasized, because what screening does, it tries to catch a cancer in the pre-invasive stage, meaning we try to catch a cancer in the pre-cancerous stage before it develops into an overt cancer. So screening is important, and screening needs to be encouraged. What we tend to find a lot is we have things called mass screenings, meaning a one-off screening where you come in, you're checked, and then after that you assume that you're fine, and we're happy if you're fine. But what you need to ensure is that you have the culture of going in and getting screened every so often based on whatever risk factors that you've been seeing. So it's good enough to go for these mass screening camps where you just walk in, you're screened, maybe you had a pap smear, breast exam, prostate exam, PSA checks, and all of that. But it would be nice if you could sit down with your GP or your clinician, give them a history of what your risk factors could be, or they take a history of what your risk factors could be, take a family history, hear about all your other medical conditions, and then develop an individualized screening program for you, which you follow through with. I think that is better than the mass screenings that we see taking place. And for some reason, they always take place every October. You find that all the corporates want everybody in their company to be screened. It would be good if that could be maintained for the entire, lifetime of that organization. But what you find is that people move within organizations, so they don't always continue the screenings. But it should be something that should be encouraged and done as a schedule. Now, I'm not encouraging drinking of coffee or caffeine, but we need to stop procrastinating. And I could ask, how many of you have had your annual physical this year? Maybe by show of hands, you can use the emojis to show your hands. How many have had the physical this year? Because last year was hectic. Last year we had to deal with COVID, so no one was running around getting screened. But stop procrastinating. Take action today. Do the things that you can do to modify your lifestyle. So eat right, exercise, avoid tobacco, avoid alcohol, and then go in and have your annual physical done. Get to know your family history. You'll be surprised. You may just ask, your mom, dad, or your grandparents, does anyone have cancer in my family? And you'll hear about your family history. And it's good to know such things, because we find that people may have a strong family history, but it's not immediate family. It might be like maybe one or two cousins removed that have that history, and it could be something that is useful information for us. So you can start tomorrow. I think today is almost over. And then it's not one size fits all. So we don't just do the same thing or the same treatments or the same screening for cancer for everybody. We have to individualize the treatments and the screenings and even the schedules that we have for different people. And the same thing with the treatment. Our treatment is different for different cancers, for different stages, and even for the same cancer, but in different stages. So we have to identify what it is that we want to solve and what it is that we're dealing with before we can be able to solve it. Now, we always also say that, this and that country has got better cancer treatment than our country or than Kenya and things like that. But there's a lot of efforts being done to improve cancer care in Kenya, and we should be part of that process or that change as well. And you can appreciate to see that probably in the last maybe 15 years, we didn't even have a private cancer center offering cancer treatment. Cancer treatment in Kenya used to be offered only in the national referral hospital, which was Kenyatta National Hospital. And it's only probably, just shy of 15 years that we started having private cancer care happening in this country. So steps are being done, and there's a lot being done now with cancer being even in the counties. But it all starts with you. You cannot sit down and wait for the government to be able to run out, stringent screening programs or bring out everything that we need in terms of legislation. But because government processes are slow. So I always say, start with yourself, start with your family. And if you can sort that out, then with time, the government will catch up with where we are at. It's not all doom and gloom, and there's a lot happening. In Kenya, we have legislation that is looking to improve cancer treatment, and this goes all the way from, the Cancer Control Act that was done in 2012, if I'm not wrong, to the first ladies in Africa doing a memorandum to say that cancer, to ask for what? They asked for cancer to be declared a disaster in Africa. And now we have places where you can get cancer treatments in this country, including even PET scans available. They might be a little bit exorbitant, but they are available. You don't actually have to leave the country to get that done. We are improving in terms of our surgical expertise. We have got radiotherapy and even fancy radiotherapy options available in this country. We have got chemotherapy, including targeted therapy, available in this country. We've got support groups available in this country. We've got allied services and supportive care available in this country, including palliative care. So there's a lot more that is being done. And even for those who have gotten cancer, there's a lot more in terms of support that is being done. So we need to also look on the bright side and see that a lot is being done, and we're able to cure more and more patients at the end of the day. Thank you.
Wow, thank you so much, Dr. Helena, for that very informative session. I've learned so much, and I promise you that I'll go for my screening as a result. We've had a few questions from the gallery, and I think your your talk has answered a few of them. We had a question from Mary Canero asking what the general signs and symptoms of cancer and how it can be detected. I think you've covered that in terms of going for screening, eating right, and the symptoms from various cancers that you touched on. We have another question saying, what is the target age for cervical cancer vaccine? What is the target age for the vaccine? Dr. Anna?
Thank you very much. So the target age for the vaccine, so we rolled out HPV vaccination countrywide in Kenya. It was in 2019. No, it was in 2019, if I'm not wrong. We rolled it out, and the first cohort has actually received both injections. We're giving been concentrated to girls. So we're doing it for 9-year-old girls. They're getting 2 injections, I think 6 weeks apart, and hopefully it shall be rolled out to more. So the ideal age the target age for cervical cancer vaccine in this country is 9-year-olds. For now, it is limited to girls. It can be given all the way up to about 35 years old, as long as you've been tested and found not to have you can still benefit from that. You start vaccination as early as 7-year-olds. So it depends on which country you are and what they're doing. And then, but for Kenya, we're starting at 9-year-olds.
Wonderful. So to our senior citizens, please encourage all your granddaughters at that age, try and get it. The other question is from Mary Kitaka asking, would you be able to comment on radiation exposure from airport machines, cell phones, and etc.? Is that one of the leading reasons why there has been an increase also in cancer of late?
Let me just share something. I think it's nice if we all see this. Sorry, I'm just struggling to share that. So it's the electromagnetic spectrum that I want to share. And it gives us an indication of what sort, because I get this question, especially for not just the airport machines, but even for, I don't know if you can see it on your screens. So just even for microwaves, for cell phones and things like that. So we have 2 different types of radiation. So we have non-ionizing radiation and we have ionizing radiation. So when we're looking at non-ionizing radiation, this is radiation that would be, even background radiation and things like that, but would not be able to cause damage in DNA structure and cells at the normal rates that we would see it at. For ionizing radiation, depends on how ionizing it is, but the higher the frequency of that radiation, the more it would cause damage to the DNA and cause problems. So when we're looking at non-ionizing radiation, this would go from, I think the most basic thing that we can have is light, visible light. So light from the sun. The sun has got radiation, that we know. That would be non-ionizing, but that would be on the higher end of non-ionizing radiation. Now, the things that would still be non-ionizing, but towards the lower end, is things like the power lines, radio and TV, towers, mobile phones, the microwave ovens. All those would be termed as non-ionizing radiation. The things that we should worry about when it comes to ionizing radiation is things like, X-ray, CT scans, radioactive sources, radiation and things like that. But those are, in terms of, should we be very worried about the non-ionizing radiation? If it's once off, you're not living under the power line, you're not having a lot of exposure to the low frequency radio frequencies, I don't think it's anything that you should be worried about at the end of the day. Our worry would be when we start to get towards ultraviolet to gamma rays. That is where our concern should be in terms of ionizing radiation. But for normal day-to-day living, it has not been shown to cause that much of increase in terms of developing cancer.
Thank you. One other question, Dr. Helena, is what does it mean to be in remission? We hear a lot of people who are in remission when they have cancer. What does that mean?
So remission is a term used for different cancers, and mostly we find that it's used for what we call hematological cancers. So cancers of the blood or cancers of the lymph nodes. And it means that you've gone through treatment, and at the point where you finished treatment, when they do their evaluation using different tests, they are not able to find any signs of cancer in your body. So at that point in time, they say that you are in remission. But it doesn't mean that you're clear. It means that you will still have to undergo various screening and testing or surveillance. You'll undergo surveillance for a number of years before they can say that you're in full remission and that you're cured. So at the point where you're in remission, you're still undergoing surveillance at different schedules at different times in the year. But after a couple of years, which is usually 5 years, then they tell you that you're now cured of your cancer. So remission is a state where we're not able to detect any cancer, but we are hopeful that you will be cured, but we will still keep looking out for it. I think that's how I can say it in terms of layman language.
Thank you. I'm aware of the time. We'll take one more question, and any other questions that any of you may have, please send your questions to the goaninstituteclub@gmail.com, and we'll try and send out our responses to you. This is not a topic that ends here. It's a topic that will lives with us, and any other questions, I'm sure Dr. Helena will be very happy to answer. The question I have is from Charlene, who's asking, what is your opinion on using both medical treatments for cancer like chemo and complementary natural treatment like working with a neuropath? And is this available in Kenya?
I don't know too much about neuropathic medicine. It is available in Kenya. We do have it, and we do use it together with conventional medicine. I'll say at one of the centers I practice at HCG Cancer Center, which is at Mpisha. They have a unit called Faraja Cancer Support, and we actually have a homeopathic practitioner who comes in, and we have worked together with her to be able to provide complementary care to patients. So you can use homeopathic medication, naturopathic, doesn't really alter too much in terms of treatment, conventional treatment, that is. We do have a concern when it comes to using herbal treatments, especially those ones that come in packages or capsules that we don't even know what is in them. We don't know the dosages. Then sometimes we do worry that it could cause problems for those patients, especially regarding liver function. Most of the times you'll find that people will tell you they're using herbal, natural medication, and when you check, it's just supplements, normal supplements that they would use, like calcium, magnesium, or a group of multivitamins that they're using, and usually those are fine to continue together with the normal conventional treatment. So if a patient is thinking of adding on some other treatment, it's always advisable that they speak with their clinician so that they can be able to check if that will have any interactions with their medication that they're taking or with the treatments that they're getting at the end of the day.
Thank you. Thank you so much. Thank you very much, Dr. Helena, for your time, and for everybody who's participated. I hope you've gone home with just a single message, if not the entire package. John, over to you.
Thanks, Lynette. Good afternoon, fellow members, guests, and all those connected from all over the world. It's a great pleasure to have you on this call today. Dr. Helena, thank you very, very much for a wonderful, insightful presentation. I think there's a lot of key takeaways that we can take back from your presentation. and implement in our day-to-day lives. Some of the key things that we don't normally focus on: exercising regularly or daily, eating well, immunization. And some of us who do those are also a bit afraid of going for screenings and going to doctors just for checkups. So I think these are some of the things that we need to do, so that we can identify some of the challenges we have early and deal with them. But some of the other important things that I picked up were to limit alcohol, which I think a lot of us, of course, alcohol and tobacco, which are not good for us in general. And I think those are some of the things we do. But even basic things, like as we take in our vitamin D, how do we make sure we protect our skin? So thank you very, very much. I hope that you'll share the presentation with us so that we can share it with any members or guests that request for the presentation. If you'd like a copy of the presentation, then please contact us at the Gone Institute, and we'll try and get it over to you. I'd also hope that this is not the only talk, and we have many more talks on the topic of cancer and many other topics relating to medicine and diseases later on in the year. Thank you very, very much, Lynette, for moderating this talk. It's been an excellent talk today, an excellent moderation. I must say a very, very big thank you to Abigail, sitting in Australia. Thank you very much, Abigail, for coming up with this idea. And again, as Lynette said, it's never too late. Great initiative, well organized, and thank you for thinking about us all the way from Australia and organizing this entire talk, pushing it out on social media, and getting as many participants as possible. Thank you to Jason for the technology. Without the technologies, there's not much that we can actually do. And of course, thank you to COVID, because of COVID, we've actually started using technology and are now able to host talks anywhere with people from anywhere around the world. We've had, Lynette sitting in South Africa, Helena in Nairobi. I think I'm in Makueni County. Abby's in Australia, and all this was organized from that was done. And thank you to all of you who have supported all our functions, not only this one, all our previous online functions, and please support all the others that we have lined up in the future. My request to you, please send us suggestions on what you'd like to hear, what you'd like us to host in the future. And I think one of the key things that is important for all of us is to appreciate that we need to appreciate every the time that we have, every minute of our day, every minute that we can spend either appreciating the world that we have, helping other people, the environment. There's a lot that we can do. We just need to take time and put our effort into it. So thank you all, and we hope to see you soon for another session. Lynette, thanks a lot. Over to you.
Thank you so much, John. And again, thank you so much to the Goan Institute for allowing us to help the community through various initiatives that we are coming up with. And again, thank you again for our support, for being there and helping us help you. Thanks, Abby. And thanks for staying up with us. Thanks again, Dr. Helena, and thank you, everybody. We'll see you again next time. As John said, let us know what it is that you want us to tackle. We are here. Your wish is our command. Thank you and God bless. Bye.